Hello and welcome. Today we're diving into a rare and challenging corneal condition known as Mooren's ulcer. This painful and progressive disease can threaten sight, so understanding it is crucial. Join us as we explore its causes, symptoms, diagnosis, and management. The exact cause of Mooren's ulcer remains a mystery, making it a fascinating and complex area of research. However, current theories suggest a combination of factors might be at play. These include autoimmune responses, where the body mistakenly attacks its own corneal tissue, localized vascular ischemia, meaning insufficient blood supply to the cornea, and potentially infections that trigger an inflammatory cascade. It's believed that genetic predisposition may also play a role, making some individuals more susceptible than others. Further research is definitely needed to unravel the precise etiology of this debilitating condition. Mooren's ulcer is characterized by a progressive destruction of the corneal stroma, the middle layer of the cornea. This destructive process begins at the peripheral cornea, meaning the outer edge. The ulcer then advances towards the center, undermining the overlying epithelium, which is the cornea's protective outer layer. This breakdown is mediated by inflammatory cells and enzymes, such as matrix metalloproteinases, that degrade the corneal tissue. The result is a painful and potentially sight-threatening ulcer that can progressively thin and perforate the cornea if left untreated. Mooren's ulcer is considered a rare disease, making it difficult to gather extensive epidemiological data. While it can occur in individuals of any age or ethnicity, it is often seen more frequently in certain geographical regions and populations. For example, some studies suggest a higher prevalence in Africa and Asia. Furthermore, there appears to be a slight predilection for males over females. Given its rarity, accurate prevalence figures remain challenging to obtain, and further research is needed to understand the global distribution and risk factors associated with Mooren's ulcer. The signs and symptoms of Mooren's ulcer can be quite distressing. Individuals typically experience severe pain, often described as a burning or foreign body sensation in the eye. Redness and excessive tearing are also common. Blurred vision is another frequent complaint, particularly as the ulcer progresses and affects the central cornea. A distinct characteristic is the presence of a crescent-shaped ulcer near the edge of the cornea, often accompanied by an overhanging edge of corneal tissue. Sensitivity to light, or photophobia, can also be significant, making daily activities difficult. Diagnosing Mooren's ulcer requires a thorough eye examination by an experienced ophthalmologist. The characteristic appearance of the peripheral corneal ulcer is a key diagnostic feature. However, it's crucial to rule out other conditions that can cause similar corneal ulcers, such as infectious keratitis, peripheral ulcerative keratitis associated with systemic autoimmune diseases, and other forms of corneal degeneration. Laboratory tests, including corneal scrapings for microbial analysis and blood tests to assess for autoimmune markers, may be performed to exclude other potential causes. Corneal topography, a mapping of the corneal surface, can also be helpful in assessing the extent and shape of the ulcer. While Mooren's ulcer isn't strictly classified into types, it is often categorized based on its clinical presentation and response to treatment. A more aggressive and rapidly progressive form, often referred to as aggressive Mooren's ulcer, is more common in younger patients and is associated with a poorer prognosis. In contrast, a less aggressive form may be more prevalent in older individuals and may respond better to medical management. Understanding the aggressiveness of the ulcer is crucial in guiding treatment decisions. The management of Mooren's ulcer is often challenging and requires a multi-faceted approach. Medical treatment typically involves topical corticosteroids to reduce inflammation and immunosuppressive agents, such as cyclosporin or tacrolimus, to suppress the autoimmune response. In some cases, systemic immunosuppression with medications like methotrexate or azathioprine may be necessary. Pain management is also crucial and may involve topical or oral analgesics. Surgical interventions, such as conjunctival resection, amniotic membrane transplantation, or even corneal transplantation, may be considered if medical management fails to control the disease, or if corneal perforation occurs. It's essential that treatment is tailored to the individual patient and monitored closely by an ophthalmologist experienced in managing corneal diseases. Because the exact cause of Mooren's ulcer is unknown, there are no definitive preventive measures. However, maintaining good eye hygiene and seeking prompt medical attention for any eye irritation or injury may be helpful. Individuals with a known family history of autoimmune diseases should be particularly vigilant and undergo regular eye examinations. Early detection and treatment are crucial in preventing the progression of the disease and preserving vision. The prognosis for Mooren's ulcer can vary depending on the aggressiveness of the disease and the response to treatment. While medical and surgical interventions can often control the inflammation and prevent further corneal destruction, complete resolution is not always possible. In severe cases, corneal perforation and vision loss can occur. Recent research is focusing on developing more targeted therapies, such as biologic agents that specifically target the inflammatory pathways involved in the disease. Additionally, advancements in corneal transplantation techniques are improving the outcomes for patients who require surgical intervention. Continued research is crucial to improving the long-term prognosis for individuals with Mooren's ulcer.